All right, next slide, please. And this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the grand rounds will address. Next slide, please. And now we have a brief introduction from our chief resident, Dr. Vanessa Sanchez.
Dr. Alexander Young is a clinical health psychologist with expertise in program evaluation, consultation, and chronic disease management. He collaborates with a variety of innovative health startup companies, leveraging his skills to develop and refine programs that improve patient outcomes and streamline healthcare services. A proud San Antonio native, Dr. Young brings a unique perspective to his work, combining a deep connection to his roots with a global outlook shaped by his current residence in Washington, D.C.
Awesome. Hey everybody, Dr. Young. Don't let the background fool you. I'm actually in Washington, D.C., but I like the San Antonio skyline. So today we're going to be talking about behavioral medicine and weight management, kind of from a health behavior lens, kind of an integrated care lens. Hopefully it'll be some new information, some things you haven't heard before, but hopefully it kind of overlaps some stuff you'll already know about this kind of information. So real quick, I am a health psychologist. Dr. Obaida is a health psychologist. A lot of the faculty within the family medicine department are health psychologists. And it's important to know that health psychologist is a subspecialty within the field of psychology. Similarly, there are things like neuropsychology or forensic psychology. And so health psychology is similar to those, and that is it is an umbrella, but a subspecialty within the field of psychology. And then within health psychology, I would say there's even kind of more umbrellas underneath that, right? People that specialize in broad health psychology versus people that specialize in primary care, people that specialize in other kinds of approaches, maybe like bariatrics or something like that. But it's important to know that this is a subspecialty within psychology. You can get board certified if you so choose. But what's unique about health psychology, perhaps unlike maybe a generalist, a general clinical psychologist, is that we have a broad focus on biopsychosocial approaches to care and our views of patients versus kind of an older biomedical model. We generally focus on prevention and early intervention to hopefully intervene with patients early on rather than when diseases or problems are kind of more severe or more set in. And we have an integrated care mindset, right? So this is the idea that we know that we are a part of our team. We want to engage as a team to help assist a patient or to arrest a problem. And so we're looking for that team dynamic to kind of help us with a patient or with a presenting problem. The other important thing to know is that a lot of us have more advanced knowledge, perhaps than a typical psychologist, on things like disease processes, medication, treatment, for a variety of things, right? As I mentioned, some people are very broad, some people are very specialized. So somebody might know a lot more about, pulmonary issues, right? If they are a health psychologist that focuses on pulmonary stuff versus maybe a broad health psychologist or like a primary care psychologist that has a lot of information, but on a bunch of different topics, right? So it's important to know that health psychologists have this really interesting, not only perspective, but body of knowledge that's very unique to that psychology branch versus a generalist clinical psychologist or somebody from another branch of psychology. And as you can see this nice graphic here. But there are a lot of theories that underpin health psychology, and we're going to go over 3 of them here. There's certainly more. But one of the ones to really be aware of is what's called theory of planned behavior, which is what I have here, but it really emphasizes 3 aspects, right? So attitudes, subjective norms, and then perceived behavioral control. So if we go through these, you can see the attitude is, how does the person view a behavior, right? You're trying to get a patient to take their medication, to lose weight, to do something, right? You're trying to change their behavior by some kind of action. How do they view it? What is their attitude regarding that action? A lot of times we don't stop to know, but it's really important because sometimes what we think is a positive action may not be viewed positively by the patient. Subjective norms, right? Within their family, within their system, where are the social pressures? What's the norm of a behavior for that patient, right? Is it something that's common in their culture? Is it something that's not really talked about or kind of frowned upon? And the last one, which is really, really important, and I want to put an emphasis on perceived here, is perceived behavioral control. What does the patient feel that they can control as it relates to the behavior? It may be very simple to you or I, right? Of course you can go to the store. Of course you can, go walk down the block. But do they feel that they can? Do they feel that they can actually control that behavior? Because if they can't, then that's a big problem. So an example I have as it relates to kind of weight management is a person may adopt healthier eating habits if they believe it's good for them, right? That these foods will improve my health. It's important people in their life support it. So family is engaged, the spouse is engaged, there's other kind of support within the system, and they feel that they can actually control their diet, right? So they, of course, probably can physically, but is that perceived control there, right? Can they really actually envision themselves going to the store, purchasing those foods, walking down the street in a safe way, engaging in exercise when they have a very busy a very busy social schedule, or family dynamic, right? So these three things are really, really important when you start to think about how am I going to get a person to change their behavior. The next one kind of builds on the other one, which is called social cognitive theory. And I won't go through all of these, but I'll touch on these last two here. So we have the first one, which is reciprocal determinism. It just means that there's a big interaction within the system, right? Between the person, a behavior, and the environment, right? So it's not just the person in a silo. We need to understand that there's a broad kind of interplaying interdynamic system that occurs when we're asking people to change things. The second one is observational learning, right? We think about this with children, but adults do this too, right? We learn by watching other people. We learn where the entrance or exit is to a building by watching somebody go in or go out, right? We watch somebody be successful with exercising or with diet change, and we try to emulate that. We try to copy it, right? And then self-efficacy, right? Again, going back to this idea of control, that I can actually do this behavior, right? That I'm strong enough, that I'm capable enough, right? All of those things. I have the ability to do this, to be successful in doing this. So an example of this might be a person who begins exercising regularly after observing their friends do this, being successfully, and then they successfully incorporate fitness into their life, right? Because they've seen it, they see the system, they have that support, and they feel they can actually perform this behavior successfully. The last one, which I think is probably much more common and probably more known to the broader group, is this idea of the health belief model, right? It's been around for a long time, another branch, social psychology, invented in the 1950s. And it has really gone well beyond what it was intended to do now, to kind of look at all preventative actions for illness and chronic diseases. But this really focuses on the idea of trying to predict health behaviors by focusing on individuals' attitudes and beliefs about the behavior. And I have a little graphic I'll show you here in a second. So this is a broad kind of emphasis of this model, right? You have cues to action, maybe something on the news or a commercial or something happening. Health behavior change here at the very end, and then you have to kind of work backwards here, right? So we have the perceived threat and then self-efficacy. So on the left-hand side, how susceptible am I to getting a disease or a condition? If I do get it, how severe is it going to be, right? So that's the perceived threat. Perceived benefit, if I do act, what benefits might be there to kind of exercising? What barriers are going to be there? And that's self-efficacy, right? So these two things kind of duel each other. And if the equation is right, health behavior change occurs, right? So as an example, as it relates to weight management, and I did this related to like comorbid conditions, it's likely that I will get diabetes if I'm overweight, right? Well, how bad would the diabetes actually be, right? So I have to have a belief in the threat of comorbidities related to my obesity. But to have self-efficacy, I have to engage in health behaviors to stop me from getting diabetes, right? And the barrier that I often hear, and I'm sure you often hear, is I don't have time to commit to this, right? So I'm confident I can start a health behavior, let's just say in this equation, and you might get health behavior, right? So I believe that comorbidities are a threat to me. I'm confident I can start and be successful in a health behavior change. And so I'll engage in a health behavior, right? But it's really important when you start to see patients that you evaluate these things, right? If I'm asking somebody to engage in lifestyle management changes, right? If I'm asking them to change their diet, starting to think about how do they view their problem? Do they even understand it, or do they view it as a problem? And then how do they see their ability to actually engage in that intervention, right? Because if these equations aren't how they should be, health behavior change won't happen, right? And you've wasted your visit, you've talked a lot, and the patient's just kind of nodding their head, and nothing really changes in the next visit. They're still doing the same thing they did before. So it's really important. All three of these theories are important, but for practicality, the health belief model I think can be used very, very easily and very saliently within visits. So some data in primary care related to eating disorders and weight management. So depending on the study that you look at, because there's a lot of them, there is a large gap in data related to primary care settings and eating disorders and disordered eating. So one study I found that it's about at 100 per 100,000 people, higher among females for adolescents and young adults. However, binge eating disorder shows up in a community sample around 2 to 3% within the general population, but in weight management settings, it's up to 30%, and those with severe obesity, it's closer to 50%. Now, as I mentioned, there are a lot of data gaps because there's nothing I could find that really cemented percentages and population metrics. But I was able to find some kind of stuff from other countries. So the lifetime risk for an eating disorder just broadly in women is about 8%, men is 2%, but broad population models, so this is in the United States and outside of the United States, really puts it closer to 19% for women and 13% for men. Now, as I mentioned, United States, a little difficult to find, but Australia had a great study that showed that out of 1.5 million primary care encounters, they found that the incidence of probable eating disorder was 0.32%, which is somewhat small. However, it's really important to remember that this particular study was looking at eating disorders and not disordered eating, right? So there's a big difference. Eating disorders, very well defined, look in the DSM-5, you can find, check A, B, and C and find it. Disordered eating or, eating that just isn't healthy or is kind of triggered but doesn't kind of really meet that criteria for eating disorder isn't really well captured. And it's really not well captured in literature either, unfortunately, especially really related to primary care settings. But one of the interesting things about this study is that most encounters for eating disorders, about almost 60%, were initiated for other reasons outside of eating disorders. So when you think about people coming to primary care, they oftentimes are not coming for eating disorder treatment, right? They're not coming and presenting to say, hey, I have a problem with disordered eating. I'm losing weight or I'm gaining too much weight. A lot of times these are found through discussion, through conversation, sometimes with primary care providers, sometimes in integrated settings by the behavioral provider. The other thing to be aware of is in the same study, they found that as it relates to referrals, 20% of those patients were referred to mental health specialists, 8% to medical specialists for secondary conditions, and then 6% to nutritionists and dietitians. Again, out of Australia, not necessarily the US, but important things to think about, when we're thinking about disordered eating or eating disorders, that most people are not coming for that specific concern. And if they are presenting, right, we need to kind of figure out where are we referring them to and how are we going to get them access to care. So there are not that many, surprisingly, screeners for eating disorders in the primary care setting. There are a lot of them, but a lot of them are not conducive for the amount of time within primary care, but there are a few of them. So the first one is the SCOFF questionnaire, which is this top one up here. I like it because it's very conversational, right? It's very just kind of simple questions. And you can see at the bottom here, an abnormal response is considered a positive screen if there are two or more questions that are answered affirmatively. This one is obviously for the UK, 1 stone, but it comes out here for 14 pounds. But the nice thing about this is that this is for eating disorders, but it can also touch for disordered eating. There's another one called the EDS-PC, or the Eating Disorder Screen for Primary Care, also more conversational or kind of question-oriented, that isn't too just kind of in your face, do you have an eating disorder? And it's down here. This one, 3 or more, is considered a positive screen. But both of these, very simple, very easy to kind of interject into interviews or to have on intake questionnaires, right, for people sitting in the lobby or waiting to be seen. So I really like these just because they're simple and easy. There's another one, I think a lot of people are familiar with SBIRT. There is now an SBIRT ED. I haven't found a paper version. This is one that's online, but it is also only 5 questions, which is really nice. And it's a yes or no thing, right? So similar to the other ones, perhaps not as broad question oriented, just kind of yes or no question marks or check marks, but it can also be given as a brief kind of screener. So SBIRT has kind of come out with this eating disorder screener for primary care, which is nice. One thing to be aware of, and one of the reasons why I really want to make this distinction between disordered eating and eating disorders, is that the literature on eating disorders has changed over the years. So a lot of people, I think, maybe you do, I wouldn't expect you to, but the DSM is what psychologists, mental health providers, psychiatrists use for diagnosing. I imagine primary care providers are somewhat familiar with it, probably not as much as we are, but these are iterations of this mental health Bible, if you will. They don't come out every year, they come out every couple years, and there's usually an original and a revised version. But you can see that about 2 iterations, and there's another revision one here that's not captured, but you can see about 2 iterations ago, there were only really 2, 3 eating disorders, right? So anorexia, bulimia, which included binge eating behavior, and then eating disorder not otherwise specified. So everything else that kind of we weren't sure about. Then the next iteration, DSM-4, you have 2 of them, and then you have eating disorder not otherwise specified, and binge eating behavior has been moved into this other category. Now, the current one, which is DSM-5, which is the new one, includes all of them, right? So we have anorexia, we have RFID, which is restrictive food intake disorder, bulimia. You have binge eating disorder, which has finally got its recognition. You have other specified eating disorders, so atypical versions of these, as well as some other symptoms. And then you still have this kind of unspecified or unidentified kind of eating disorder box that's just kind of the catch-all for everything else that kind of shows up. So it's important to realize that a lot of studies are looking at eating disorders, right, and kind of using these kind of categorical boxes, with DSM-5 being the most recent one. But disordered eating, I think, is much more common in primary care populations and in people in general, right? People that do fad diets, people that are having maybe health anxiety or food anxiety related to a secondary condition, right? Maybe they're afraid to eat because of their diabetes or high blood pressure, right? That certainly doesn't meet criteria for an eating disorder, but it might be disordered eating. So it's just important to realize that this category of mental health is expanding, is evolving, and a lot of literature, a lot of research focuses on eating disorders and not necessarily disordered eating, which I think is, like I said, is much more common. So to talk a little bit about primary care behavioral health and the PCBH model, just to throw it in there, this is the model that is used in most primary care settings. Well, at least the one that y'all are in. And it's kind of growing, I think, this PCBH model. Dr. Obaid has certainly been an amazing person to kind of grow this within San Antonio and within the region of South Texas. But one thing that I always want to make sure that providers understand, especially medical providers, is that health psychologists and integrated care psychologists, we are really experts in behavior change, which is why I really emphasized those 3 theories earlier. A lot of medical providers, and a lot of providers just in general, right? A lot of people think that, oh, you just do mental health, you just do therapy. And while there's a piece of that that's certainly true, there's so much more that we can do to assist patients, especially as it relates to eating disorders and disordered eating. We are behavioral health consultants, not therapists, not just broad mental health. We are oftentimes functionally focused versus symptom focused. You can certainly be symptom-free and still not functional in a way you want to be. You know, when you think about people that have all the medications in the world, they certainly are symptom-free, but maybe they're so fatigued or they're so kind of just out of it from their medication, they don't feel like themselves, they're not functional. So I think functionality is something that we often really focus on, because a lot of times if we can focus on function, symptoms tend to improve as a side effect, so kind of going backwards. PCBH model emphasizes short visits, 20 to 30 minutes on average, depending on the patient and the need. Depending on the clinic, short-term visits, 4 to 6 visits on average, but it usually depends on where you are. Spread out over time. And we follow the GATHER acronym, which is just a broad acronym to kind of explain the way that we approach not only care, but also approach kind of our team dynamics with others. So problems for you to be aware of that, PCBH providers can assist with: mild to moderate mental health conditions, as well as all of these health behaviors and more, right? I don't want to make the slide too long, but we'll focus on obesity and weight loss for the rest of the presentation. But it's important to know that a lot of times disordered eating can sometimes fit into these, right? Diabetes, high blood pressure, sometimes headaches, other conditions. People can become afraid of eating because they're unsure of food-related triggers or other, triggers within their diet. We can also do anticipatory guidance. Interventions. So I think most medical providers are familiar with CBT, which is great. It certainly works for a lot of things, but there are many other interventions that fit well within the 20 to 30-minute visit. Mindfulness-based cognitive therapy, which is kind of like a sister version to CBT. Acceptance and commitment therapy, which is maybe like a cousin to CBT. There's also a more focused version of this called focused acceptance and commitment therapy, which is more kind of surgical in the way that it approaches patients. Motivational interviewing, which most people are familiar with, and then solution-focused therapy. There are other ones, of course, but these are kind of maybe some bigger ones that are often utilized with patients. Broad skill development and then coping skills. So this is some broad research just to support the idea of PCBH being successful. A large study, about 500-ish people were evaluated. 71% of the patients showed improvement, with 40% showing reliable improvement over time. A broad meta-analysis looking at 14 studies involving PCBH approach, looked at kind of older primary care patients, and found that when this was utilized, they found a statistical reduction in depression and an increase in mental health functioning, which is awesome, especially in older adults. Another meta-analysis across 20 studies found that there was functional improvement of patients in all 20 studies, which is really impressive, with an overall reduction in mental health symptoms. Again, this idea of focusing on function with the assumption that symptoms will improve as people become more functional. And then lastly, which I think is really, really important, this idea of patient satisfaction. It was found to be excellent, right, with patients that engaged in this type of care, and they reported that they would likely recommend it to other people and would return to this care if need be, which I think is really important because oftentimes studies look at provider satisfaction and systemic kind of improvements, but really don't pay a lot of attention to how satisfied is the patient, how much is the patient getting out of this, and obviously would they come back for this type of care, and in this case, they certainly would. Some sample dialogue, I won't read this, but Dr. Obaid has a great version of this, but this is just a sample statement that you might share with a patient that you identify that might benefit from seeing a behavioral health provider. There are a lot of versions of this, but this is just a very simple, easy statement to give. This is for another organization I provided this talk to, but something similar might be effective for your clinic. All right, so let's get into some emotional eating stuff. So stressed is desserts, spelled backwards. I thought that this was a hilarious graphic, and it's very true. But it's really important to also talk about what is emotional eating. What is it really, right? So emotional eating is what we see. Emotional distress is oftentimes what is underneath it. So emotional distress really is this idea of reduced cognitive resources and resilience related to a lot of things, right? Related to stress, related to being overwhelmed by different things within someone's life, difficult work, difficult family. But a lot of times what happens is when people start to engage in emotional eating, they start to change their eating behaviors. And a lot of times they'll start to impulsively eat things, work on short-term relief strategies, they'll avoid good eating habits, and unfortunately start to eat irregularly. But a lot of times what happens is people start to develop this first one, which is behavioral associations. This is the idea of associating an emotion or something, right, with food. So every time I'm stressed, I'm going to stop at McDonald's. Every time I'm angry, I'm going to go get ice cream, right? This idea of every time I fill in the blank, I've associated it now with food. And this happens sometimes very quickly for some people. And it can be very difficult to break these associations once they get started. Sometimes they're broad food categories, right? I want something sweet, salty, whatever. For some people, they're very specific, right? I want McDonald's, I want Taco Bell, I want Burger King, or whatever it is, right? So it's important to realize that when you see emotional eating or when people are describing this, a lot of times it's related to emotional distress that just kind of snowballs. Emotional triggers, as I mentioned, stress, unconscious eating, eating at our desk, eating when we're doing other things. People that have low distress tolerance sometimes will emotionally eat. Over time, people can develop a hyper focus on food. That's the only thing they think about. It's the only thing that they focus on during their day. It can also cause a lot of distraction, a lot of issues with focus and attention. Over time, and I have a little graphic for this, people can develop body shame, which can also be a trigger. But one of the things that can happen is that if people are too hungry because they're skipping meals, or people are too tired because they're stressed and not sleeping, they're less likely to be able to fight off cravings, right? If I'm not resilient, right? If I don't have the energy, it's much easier to go to McDonald's than to actually make food at home, right? Or if I'm too tired or too worn out from other things, it's much easier to get that quick thing or that sugary thing. The other thing that I've noticed just observationally with seeing weight management patients is that a lot of weight management patients oftentimes have a lack of sources of other pleasure. What I mean by that is that when you start to talk to patients about what do you do for fun? What do you like to engage in? What hobbies do you have? There's oftentimes a huge lack of this, right? They don't do a lot of things. They're not engaged in stuff. It's just work, maybe family, and eating, right? And sometimes it's just eating, right? Because that's just what they hyper focus on. So sometimes this idea of their world getting smaller and smaller can sometimes be a big issue, or kind of a big dynamic to kind of be aware of, related to disordered eating or emotional eating. I'm not going to go over all of this. This is the DSM criteria for binge eating. Essentially, you'll see you have to have the first one, so recurrent persistent episodes of binge eating, which is a loss of control and eating more in a discrete time frame than the average person, right? So in a given 2-hour time frame, let's say, you're eating more than the typical person. You have to have both of those, and then these other 3 or more associated criteria. And then some of these other ones here on the right. But it's important to note, and the reason why I like to say disordered eating versus eating disorder is because in order for you to have binge eating disorder, it has to occur at least once a week for 3 months. That's a long time. If you try to get patients to think back for 3 months, at least once a week, people are not great historians. I don't know that I would know that if I'm doing this once a week, right? Certainly, and at maybe a moderate to severe range, patients are very aware, but maybe on that more mild range, mild to moderate, patients probably don't remember this, right? Or may not know this. The other thing is that you can be diagnosed with binge eating disorder if it has a low frequency or limited duration. There's an exception for this kind of once a week for at least 3 months. But in practice, I have not seen psychologists diagnose binge eating disorder if there is a low frequency, mostly due to confusion, because if the patient doesn't meet all of this criteria, but you're still giving them this, and maybe not including this kind of asterisk or this kind of demarcation, and their records get sent somewhere or they get transferred somewhere, it may misrepresent the patient, right? It may say, maybe this person has binge eating disorder, but it's very mild or it's very limited, right? Most people will use this other specified, right? Category that I mentioned earlier, rather than giving them the full binge eating disorder. So it's important to know that while this is, I think, becoming more commonly recognized, it certainly is more noticeable in patients that I've seen. This outlier here of once a week for 3 months is something to be aware of. And again, this idea of eating disorder versus disordered eating, and where are we kind of putting that, where are we putting it, right? In what bucket are we going to put it in? This is ARFID, avoidant restrictive food intake disorder. Again, something I'm not going to go over all the way, but just something to be aware of. It's a newer diagnosis through the DSM-5. It's something that I have started to see a little bit in the work with weight management patients that I have. But it's important to know that this is not the idea of fasting, right? This is really the idea of being very almost picky with food, but it's kind of to an extreme or to a severe level. It's also important to realize that this is not in the context of another eating disorder. It is not associated with body shape or weight, right? This is really this idea of just being very like overly selective, overly restrictive of food, and not really caring about their body shape or the weight. It's not really about that. It's really about the food itself. So just something to be aware of. Again, it's a newer diagnosis. It's not something seen very common. It's somewhat rare within the eating disorder community, but it is something that you may see. And then body dysmorphic disorder. This is another one that is starting to become more common or more recognized, I suppose. But this one is more with the idea of the preoccupation with defects or flaws in physical appearance that you or I may not notice or see. One thing to be aware of is that this preoccupation is not better explained by concerns with body fat or weight in an individual whose symptoms meet criteria for an eating disorder. In my experience, if somebody has an eating disorder or disordered eating and they have these kind of concerns, right, it really is a facet of the eating disorder itself, not necessarily a whole separate condition. Certainly, we want to try to limit the amount of diagnosing and the amount of kind of overlap that we're giving patients as far as it relates to how many things are we giving them. But it's important to know that if somebody has these concerns in an eating disorder, it is oftentimes viewed as an eating disorder kind of capsule rather than this idea of this separate condition or this extra thing on top of the eating disorder, which I think makes a lot of sense. So this is a broad example of maybe binge eating disorder. I think just disordered eating in general. You have someone here at the top, food restriction or dieting, whatever you want to kind of put here as kind of restriction. You have deprivation, which comes in many forms. So I'm not going to eat carbs, let's just say. But I had a really bad day, right? Something really crazy happened and I had a cookie, right? I had more carbs than I wanted. I temporarily feel better because the cookie is really great. But I'm disappointed that I ate the carbs because I'm on a low carb diet. What am I going to do now, right? And so now I'm anxious because, gosh, I've thrown off my whole diet. I'm depressed because I'm trying to lose weight and I'm going to look terrible for my, summer, whatever it is. And I've already eaten the cookie, so I've already gone over my carbs. Why not I just have another cookie, right? Maybe another cookie. Maybe just a donut, right? Or I'll just have a pizza or whatever it is, right? This idea of coming back down to eat to feel better, again, feeling better temporarily, disappointed, and then this negative emotion loop, right? Oftentimes this happens briefly, and then people will go back to restriction. And inevitably, people will repeat this cycle, which is why food restriction oftentimes does not work well as a dieting strategy for almost anybody, because it oftentimes leads to this idea of deprivation. How long can I deprive myself of something that I really want or something that I enjoy? And inevitably, stress or some other kind of factor will lead me to eat it, and this cycle will unfortunately occur. Oftentimes, people can get stuck in this cycle, sometimes leading to binge eating, sometimes leading to disordered eating. But this is just kind of a broad illustration of what kind of disordered eating can kind of look like, or other types of eating. Some unhelpful eating behaviors, there are a lot of them. Excessive snacking and grazing, overeating, obviously. One thing I found a lot of times in COVID, that I find it a lot now as well, is eating in conflicted environments, which I'll come back to here. Skipping meals or restricted eating. I have a lot of patients, for some reason, they think if I skip breakfast and lunch, but only eat dinner, I'm going to lose weight, right? I'm going to be in such a calorie deficit that the weight's just going to fall off. And, going back to this cycle here, because they're depriving themselves, oftentimes what happens is they've slowed their metabolism so slow because they're starving themselves, that when they do eat something extra, the body holds on to it, or they will binge eat at night or late night snack because they're so hungry from not eating breakfast or lunch, right? So oftentimes this idea of deprivation through restriction, like complete restriction, almost always backfires. But eating in a conflicted environment is something that I see more and more. Oftentimes I'm sure y'all as primary care providers are guilty of it. I am certainly guilty of it. Eating at our desk, right? Eating at our computer, eating at an inappropriate place, right? Because we're so busy, we're doing all of these things. And this is the idea of a conflicted environment. One thing that happened in COVID times is a lot of people were working in their kitchen because people didn't have, another room as a home office or stuff, or they would work in their bedroom. And what do we do in the kitchen, right? We eat, we cook, we do kind of more socially things. And so as a lot of people were working, they would kind of unconsciously munch and just kind of snack and graze and stuff. And we're not paying attention, right? We're not paying attention to the quantity that we're consuming. We may be aware of what we're eating, but certainly not the volume. Have I had enough? Am I still hungry, right? All of those things, the hunger cues, satiation cues, we're not really paying attention to those. And when we're mindlessly eating in conflicted environments, it makes it that much easier. Coincidentally, people that work in their bedroom or do other things in their bedroom oftentimes create conflicts related to sleeping behavior, right? So if I'm in my room, but I'm also stressed in my room because I work in my bedroom and maybe I snack in my bedroom, the mind gets a little confused about what am I doing in my bedroom? Am I sleeping? Am I eating? Am I working? This can be expanded to other environments of I'm in the kitchen. Am I in the break room? Am I at my office? What am I doing in this moment? And am I splitting it with something else? So oftentimes something I see, and it often unfortunately affects people in a negative way. One thing that I often encourage patients to do is to really try to aim for 20 minutes per meal. Obviously, this is not the case for every single meal. Some patients, and myself included, I don't spend 20 minutes maybe eating breakfast because it's small, but a normal everyday meal should roughly be 20 minutes. That's about as long as it takes your stomach to tell your brain that it's full. And oftentimes, if you ask patients, well, how quickly do you finish a meal? Most people have no idea, right? Until they set a timer. And I've had patients say, gosh, I didn't realize I finished a meal in 5 minutes, 7 minutes. I had a patient the other day that was like, I finished a meal in like 3 to 4 minutes. That's incredibly fast, right? And leads to people feeling stuffed, to people maybe overeating, or just not eating in a way that is really healthy, right? But in our kind of go, go, go lives, I think a lot of people become victims to that. This is another example of negative eating cycles. This one is more CBT oriented, but you have a stressful something here, a trigger, thoughts about the trigger. I'm an idiot, I can't do anything right. Emotion, thoughts, behavior to eat, right? To eat to feel better, which is a lot of people's cue. So negative thing happens, I think about it, I have an emotion, think about it some more, I eat to feel better, I feel bad. Consequence, I start to gain weight in this example. And because I've gained weight, maybe now the thought is, gosh, I feel really heavy. I feel really fat. Maybe I'm just an ugly person, right? Maybe that's the thought, right? And now I feel really sad because my self-esteem is impacted. And, it just becomes this very vicious cycle. And it's important to realize that these things can happen very quickly, but they can also happen in other health conditions, which I mentioned, like, for example, diabetes, right? People get bad news about their diabetes. Their A1C is really high, it's a 10. Or, they went to the doctor and their blood pressure is super high, right? Maybe the thought is, my body is not safe, right? I'm doing something wrong. I don't know what I'm doing wrong, but I'm doing something wrong. So I feel really nervous. And maybe it's my food. Maybe I should not be eating things. And so I restrict my behavior. I restrict my eating, or I only eat, let's just say carrots in this example. And maybe I feel anxious, right? I feel nervous. And the consequences, I have high anxiety now. I've restricted my food, so I'm losing too much weight, right? Or I'm gaining weight, whatever it might be. But that can also be kind of this circular reasoning of, I'm getting negative news about a chronic health condition. If it is related to my consumption of food or drinks, maybe this is going to become something I focus on, and maybe I change my behavior in a way that is not helpful, but is rather maladaptive. These are some very broad general coping strategies. Managing stress, always, there's a million ways to do this. Obviously, your BHC will kind of target whatever is needed for the patient. Drinking water before eating. especially for patients that binge eat or have disordered eating. Obviously, it depends on the type of disordered eating, but because people are often dehydrated rather than hungry, sometimes hunger cues are really thirst cues. So sometimes drinking water can be very effective. Avoiding or minimizing access, so not buying the comfort food, snacks, or fast food, going a different direction to home or work or whatever it is. Mindful eating, which we'll talk about here in a second. Relaxation, regular exercise. This one here, values-based distraction, this really goes back to this idea of engagement, right? So asking patients, if you decide to target this or if you decide to kind of notice this with your patients, what's going on in your life, right? What are you engaged in? What do you do for fun? Not too much. Okay. What is important to you, right? What are some kind of areas of your life that are important to you? Is it sports? Is it traveling? Is it money? Is it family? Whatever it is, right? And starting to identify those values, those broad umbrellas, and then saying, if family is important, what is one thing you could do to kind of work towards that value of family, right? What's one thing you could do this week or next week to kind of re-engage in that value, right? Something small. Obviously, the BHC will help you with that more, but just something small, right? This idea of re-engaging patients in their life to try to move them a little bit away from that association or hyperfixation on food and more into other areas of their life. So mindful eating is really, really helpful. It is really helpful at recognizing satiation cues, fullness cues, and hunger cues. So what are we eating? How are we eating it? And eating it slowly with awareness, right? So again, spending 20 minutes to kind of really figure out, is this something that I enjoy eating? Is this something that I like the texture of? Is this something that is satisfying my hunger? Am I still hungry after eating this? Or am I satiated, right? Am I no longer hungry? If you ask patients, and I've asked myself this sometimes, do I know what satiation feels like, right? Most people don't, because we eat a lot of times well beyond that level, right? We eat to fullness. But satiation really is this idea of eating in a more mindful way to say, you know what, I've eaten enough that I am no longer hungry. And so I'm going to stop, right? I'm going to stop because that hunger cue has dissipated. But it's important to ask ourselves these questions, right, related to mindful eating. So how long does it take you to eat, right? Have you measured your own eating behavior? What do you do while eating, right? Are you somebody that multitasks? Are you someone that is always doing something else? Where do you eat, right? Do you eat in a conflicted environment? Do you know your hunger cues, your fullness cues, your stuffed satiation cues? What bodily sensations do you feel after eating, right? If you're always full, if you're always stuffed, or maybe you're always left hungry, right? That over restriction. And then what does your food actually taste like, right? Do you enjoy that mayonnaise, or do you enjoy the flavor of the sandwich? Or are you just eating it to eat it, right? Are you just eating it because it's fast, quick, and easy, because the calories are there? These are some really important questions, not only to ask our patients, but really to ask ourselves so that we have that information to improve our own behavior, but also so that we can learn more about those things for ourselves so we can better help patients that might need it related to eating challenges. This is from an old handout, just broad behavioral strategies to help with changes in eating behaviors. They're very kind of generalized, limiting salad dressing, don't clean your plate, especially for older adults, which was kind of the norm. Limiting alcohol, because a lot of patients don't realize how many calories are in alcohol. And then just being aware of other things like, chips or the bread basket that might be on the table. Mindless eating, which we've talked a little bit about, I won't go into it too much, but really this idea of eating at the same time as doing something else, really not being aware of our own consumption. So, watching TV and eating chips, sitting at work in front of the computer and just kind of grazing, eating popcorn out of a bucket at a movie. I mean, these are just kind of broad examples. Mindless eating, though, it's important to know that there's usually less awareness of the food that we've consumed, which I mentioned. There's also less enjoyment, right? Because a lot of times you're not tasting your food, you're not enjoying it, you're focused on something else. A lot of times people will engage in this if they have disordered eating, which tends to worsen body perception or body image. A lot of times I'll have patients say, well, I feel like I've just gained all this weight, or I looked in the mirror, or I stepped on the scale and 10 pounds just magically showed up. And a lot of times this comes back to this idea of mindless eating, right? This idea of I'm eating, but I'm not really aware of what I'm consuming. And when I am aware, when I am mindful of my actions, I'm surprised and I'm hurt by them. But a lot of people end up going back to mindless eating as a coping strategy, right? Because that's just what they've done. Disruption with the mind-body connection, again, this idea of, do I know my own hunger cues, my own satiation cues, etc. This gets a little disrupted with mindless eating because, again, we're not focused on it, right? We're kind of mindless rather than mindful. This is, this thing here on the right is something I actually took from a study that had a nice graphic that just talked about this idea of what can primary care providers do as it relates to people with eating disorder. This one's specific for eating disorders, but disordered eating works well as well. But it starts with this idea of history, physical examination, testing, assessing, and then kind of treating, right? So does this person need typically preferred treatment, which might be, if it's disordered eating or weight management, PCBH care? Does this somebody that needs a consultation, right? Somebody I'm not too sure about, maybe somebody that needs some specialization, some kind of further consultation, or is this someone that needs specialized care, right? Someone that needs like an eating disorder clinic or something like that. Obviously, these are a little bit different because this is not made for an integrated setting, but I like this first part here. As a primary care provider, it's important to ask, the history here that I have on the left-hand side. So can we discuss what you typically eat, right? Would it be okay if we discussed your eating habits? Getting a really, really good history of the patient's eating behavior and just some things that surround it, right? Because sometimes what sounds like disordered eating or eating behavior disruptions sometimes isn't, right? It's just something that maybe they said weird or don't have a good grasp of what they're sharing with you. But we take it to mean something that's much more severe than it is. So getting a really good history related to their eating behaviors, maybe what's driving them, when did it start, what it might be related to. Other thing is to rule out medical conditions or rule in medical conditions, things like thyroid issues, stomach conditions, hormonal difficulties, things like that. Medication, right? Are they on medication that's weight positive, weight neutral, weight negative? Did they start something that maybe last visit or by another provider that is causing them to gain weight unexpectedly or perhaps lose weight unexpectedly? A lot of times that can be missed or not accounted for. So eating concerns, right? Actually asking the patient what is concerning to them. When is it concerning? Again, getting this good history. How is it distressing? And then talking about their motivation. And the reason why I bring up motivation is because it's really important to know that if a patient is not motivated, it really is like 50, in my opinion, like 50 to 80% of whether a patient's going to engage in behavior change, maybe even a little more than that. If they're not motivated to change their behavior, if they're not motivated to engage in some kind of intervention, then we're not going to get very far, right? We can certainly take the history, take the concerns, give a handout, give our verbal recommendation. But at the end of the day, if patients aren't interested or aren't willing to kind of engage in their own care, right? If they're not motivated for that, then we're kind of wasting both of our time, right? So when you're seeing someone that has disordered eating or an eating disorder, it's really, really important to talk to them about their level of motivation. And I have some snippets here, just some little paragraphs here. So how would your life be different if you didn't need to spend so much time thinking about your eating or your consumption or however else you want to phrase it? Or how important is it for you to change your eating on a 1 to 10 scale, right? What would make it more important if they give you like a 2 or a 3, right? How can we make that a 4 or a 5, right? How can we move it up? Just to get some insight into your patient. And, like a lot of conditions where patients don't have motivation, it may be something you come back to, right, in a future visit or in another way, right? If we work on, your weight, maybe your diabetes will improve. Could we maybe work on it in that way, right? If we get you motivated because it's going to help your diabetes or it's going to help your high blood pressure, right? Working on this weight piece. But, some patients will come back 6 months to a year later and say, I appreciated that conversation. I'm glad we had that discussion about my weight or about my eating. I think I'm motivated, or I think it's a good time, right? I think X, Y, and Z that thank you for that conversation because you open the door for the patient to kind of walk through. So just some broad recommendations. Backwards. Okay. So just some broad recommendations to make sure that you try to work in there if you see anybody that has an eating disorder or disordered eating. One thing that I'll leave you with here, and this is something that I have just found to be very helpful for patients, is this idea of leaving them with a grounded thought or some kind of self-talk that is anchored in a positive. And what I mean by that is that, you know, if someone is not motivated or, and don't threaten them with this, or their motivation is lacking, right? Trying to get this idea of what's important to them, right? Their grandchildren, if it's an older patient, their family, their work, whatever, and using that as that motivation, right? To get them to kind of think about it, to get them to use it as this anchoring statement to help them push through those difficult times, right? So, and examples of these, I want to live to see my grandchildren grow up, right? So when I have that stress, instead of going to McDonald's to go get a Big Mac or whatever, I'm going to tell myself I want to live to see my grandchildren grow up, so I'm not going to go do that, right? I'm going to go home, or if I do go to McDonald's, I'm going to get something healthier, a salad, chicken, whatever. I want to get off this medication, which I hear from a lot of chronic condition patients, as a way to remind themselves of this is why I'm doing this. This is why I'm trying to motivate myself, to try to push myself to lose weight, to change my health behaviors, to improve my health, because I want this to happen, right? This kind of reminder. I'm worth the effort. I'm going to do it. I can do this, right? I know these things sound hokey. I know these things are small, but in the moment, in those stressful experiences, trying to engender this anchored, positive, grounding thought or self-talk can really, really be helpful for a lot of patients. And it's so simple, so easy that there's really no barriers to patients using this if they're trying to change their behaviors. And then some brief references, and that's it. All right. Anybody have any questions?
I don't think we have any questions on our end, Dr. Young.
Thank you. Sorry, you're a little loud. Awesome. Well, if anybody does have any questions, feel free to reach out to me. Otherwise, I hope you learned something. Hopefully you got something from it. And otherwise, I hope you'll have a good rest of your week, okay?
Thank you.
Thank you so much. Likewise.